Alright, so now let's talk about the mechanisms that cause damage. So we should see this, we should see initiation of the damage, how the damage starts, progression of the damage, how it develops, and then complications of the damage, what happens, once it becomes unstable. So let's start. First of all, I'm going to discuss two primary factors that would cause the damage: hypertension and lipids, or hypercholesterol or hyperlipidemias. There are other factors that can cause damage to the endothelium. For example, there are infections that can cause damage, and there are so many other factors. So let's start with the hypertension first of all. Look, the endothelial cells, so this is a blood vessel, and these cells here are the endothelial cells, and the blood passing through the vessel is in a laminar flow. So this is like the blood is caressing the cells on the way out. So it's kind of touching them and saying, hey, nice cell, how are you doing? So it is going through that laminar flow. Cells really love the laminar flow. Do you know this? That if you caress a cell, if you kind of, love a cell and you touch it, what does that cell do? The cell's cytoskeleton makes sure that the nucleus receives the signal to open up the gene for SOD, superoxide dismutase, which kills radical oxygen species or reactive oxygen species, ROS. So the cells that are exposed to the laminar blood flow have increased levels of superoxide dismutases. They are protected from oxygen species. They are protected from atherosclerosis. This mechanism is called anti-atherosclerotic mechanism or atheroprotective mechanism. Now, it is funny. So we have one more cell. So let's take this cell here, and that cell is enjoying increased SOD. Here we put the same cell, and now this cell is sitting in a turbulent flow. Blood is coming and sloshing and running fast, and it is hitting this cell. The cell is like going all over the places. Oh, the blood is coming, RBC hit me. What happens to this cell? The cytoskeleton is all mushy and running, and is stretched and shrunk and sheared. The shearing effect of this turbulence causes the superoxide dismutase gene to somehow close. So think about it, what's going to happen now? SOD is not present, reactive oxygen species are going to start becoming active. They would cause damage. They would damage the cell membranes, they are going to start damaging the proteins, and soon the cell is going to become damaged. What will cell do? When there are increased reactive oxygen species, it tries to protect itself from that, and it would start becoming active and trying to create cytokines. Inflammation will start. So please remember, in hypertension, one primary mechanism of starting the endothelial injury, people just say, well, the turbulent flow causes the endothelial injury. Yes, that is correct. How does it cause the endothelial injury? This is the mechanism. Alright, so that is one mechanism. Another mechanism with the lipids, LDL levels. LDL, the low life DL. HDL, high flying guy. HDL is a good cholesterol, LDL is a bad cholesterol. Why is that? HDL takes the cholesterol from the cells, it sucks them up and takes them back to the liver and gives it to the liver to take care of it. LDL takes it from the liver and says, oh, I'm going to bring a gift to the cells and give it to them. So is this a bad thing that there is cholesterol being brought to the cells? Not really. We make hormones with the cholesterol, so it's not entirely a bad thing. Cholesterol is part of the cell membranes, and it creates the fluidity of the cell membrane. If our membranes were not fluid, we will not be elastic like this and stretchy and nice like this. So the cholesterol has its function. But when there is more LDL than wanted, when there is more LDL than needed, and chronically more, please remember I said chronically more LDL, then what happens? Let's see that progression over here. What happens in that case is the LDL, so here is a LDL with the ApoB100 protein sitting on its outside. You know that what is the center of the LDL made up of? I hope that you know. If I make a quick structure of the chylomicron, it is a, instead of a bilayer for the phospholipids, it's a single layer for the phospholipids, and in the center sit the cholesterol esters and triglycerides and all those things, right? So that is what is the chylomicron, and then chylomicron has a set of handles on it which are generally made like this, but these are really proteins that are present all around this thing, and these are the proteins with which various cells can handle the chylomicron and work with it. So here we have LDL. LDL has ApoB100, and LDL receptors are present in the liver and are present on the cells. So chronically increased level of LDL ultimately causes LDL to start accumulating under the endothelium. So if you see here, I've put some phases. This is a blood vessel here. This is the lumen of the blood vessel. I have opened up the walls of the blood vessel, and we are looking at, this is the endothelium, this is the intima, media and adventitia. This is the internal elastic membrane. So all the action is in the intima. Atherosclerosis is a disease of the intima. So we're going to see how this happens. We already know that if the patient was hypertensive, then we know what would happen. The shearing effect of the cells will reduce their superoxide dismutase that would give a chance to the reactive oxygen species to cause damage, and the injury would start. So this is the column of injury. Now how would the LDL cause the injury? It would come down inside. When it comes inside, in the tunica intima, there are reactive oxygen species present here. What happens is this LDL becomes oxidized. So injury initiation has the reactive oxygen species working, or oxygen working with the LDL in the intima to create oxidized LDL. Done? Now, what is the problem with that? Look, the oxidized LDL has another problem. It would trigger, you will see that soon as we go, it would trigger more reactive oxygen species. It would trigger more ROS. Why? Because it would cause the macrophages to become active. Macrophages would release more reactive oxygen species. That would cause, so here is an interesting thing, that reactive oxygen species, increased levels, will cause, see the nitric oxide, we talked about it in our previous lectures. Nitric oxide is released from the endothelial cells. So if I make an endothelial cell over here, the cell releases nitric oxide. This nitric oxide works on the smooth muscles and relaxes them. This is a smooth muscle. The nitric oxide works on them, and we have done the pathway that how does this relax them. It relaxes the smooth muscle. That would mean that the vessel diameter would increase, vessel will be relaxed. Now tell me, if there is not enough nitric oxide, the smooth muscle relaxation would reduce. That means vasoconstriction, reduced diameter. How would that happen? Reactive oxygen species, when they act on the nitric oxide, they increase the decaying of the nitric oxide. So LDL came in, it increased the local reactive oxygen species. The result was that nitric oxide has reduced. That would cause vasoconstriction. So come here for a second. Increase reactive oxygen species, reduce nitric oxide, vasoconstriction because of increased cholesterol, hyperlipidemias. Then what? The same effect as the hypertension. Why? Why did we go back here? Why is this shearing happening now? Look guys, we have reduced the vessel diameter from here to here. The blood flow, the blood pressure has increased, right? Turbulence has appeared. That turbulence will cause shearing effect, and this mechanism of injury will start as well. So this is a very important point to remember. So anyways, so first first damage that happened was reduction of the nitric oxide. Now what happens is, this LDL, which is oxidized LDL, is a favorite of macrophages. They love it, but there are some macrophages here, but not a lot. How do we bring macrophages here? Look, the oxidized LDL does three things. Number one, it is taken up by the macrophages, which are present here already. So let me make a big macrophage here. I should make that in the intima. Let me make a big macrophage here and put some LDLs in it, oxidized LDLs. This kind of a macrophage, which has eaten up lots of lipids, is called foam cell. It is big blobby foamy cell. And actually this cell would undergo a bunch of changes. I'll talk about that in a second. But the important thing that we want to see here is that this macrophage, this is one effect of LDL, that it helps create foam cells. Second effect of the LDL is it acts on the macrophages, one, it acts on the endothelial cell, two, and it acts on the smooth muscle cell, which are present in the tunica media down here, and it causes them to release cytokines. Presence of LDL is not invited, LDL is not needed here. So presence of the LDL, the cell starts releasing cytokines. What kind of cytokines? Cell starts calling inflammatory cells to say, please come save us from this LDL. So what are we going to see? We are going to see, so see here in the monocyte macrophage part of the process, what will happen is we'll have increased monocyte chemotactic protein 1. Where is it coming from? From the macrophage. So macrophage released MCP1. It also released interleukin 1. What will these two things do? They will bring inflammatory cells over. It would also do tumor necrosis factor. What would that do? That would cause, so I'm going to make one more endothelial cell. So see, now we have to go up. Why? Because the atheroma is developing. So as we go up, let's make a cell here. This cell, endothelial cell, now has on it vessel cell adhesion molecule 1, VCAM1. So essentially what is happening is LDL caused the cells, one, it got eaten up by the macrophage, second, it caused the cells to release cytokines. The cytokines have done two things. One, they are present here in the blood and the inflammatory cells will be pulled in, and second, it has caused an effect on the endothelial cell to catch the inflammatory cells. The cell adhesion molecules are extruded and made active and made exposed. So VCAMs are present now. The result of that is going to be what? The result is we are going to have more monocytes to come in, which will convert into macrophage. Now there is a third thing that LDL does before we go to other things. A third thing that LDL does, and that is it is a poison for the cells locally. Oxidized LDL causes death of smooth muscle cells, SMCs, it kills them, smooth muscle cells. It kills the endothelial cells and it kills the macrophages. So why is that important? This is tissue damage, guys, inflammation. As soon as the tissue damage starts, as soon as the cell debris becomes available, that in itself would trigger further inflammation and pull in the inflammatory cells, repair cells. So LDL's presence has caused three basic factors. Once that is all done, the process of inflammation has started. Now in the inflammation process, it's very simple. Monocyte is brought in because there is increased VCAM, there is tumor necrosis factor out there, there is MCP1 out there, there is interleukin 1 out there. Monocyte came in. Now can I say this, that at this stage in the atheroma development, there are some old macrophages sitting there fatty and fat with the LDLs. They are foam cells. Then there are some new monocytes coming in and they will become macrophage. Why am I saying this? The new cells that are going to come in, they're going to say, oh man, this is so much damage here. I want to work. Give me work. This is the new cells that come in and start trying to bite stuff off that make the atheroma unstable. If the new cells were not coming in, if this current system just became stable by itself, it would be fine. It's the new cells that come in and say, oh, they start biting here and there. And as soon as they start biting, they make the whole thing unstable. It can rupture. Okay, so monocyte is in here. This monocyte will become converted to macrophage as well. And what would it do? Once again, it would release the reactive oxygen species. That is the function of the macrophage. I've done that in immunology. When the reactive oxygen species increase, what would happen? This whole cycle increases. Why? Reactive oxygen species works with the LDL to make it oxidized. You increase the oxygen there, reactive oxygen there, you increase oxidation of the LDL, you increase the process. See, that is why we say it is a progressive process. It won't stop. Okay, so reactive oxygen species increased. Interferon gamma, so before interferon gamma, let's say tumor necrosis factor alpha is increased. And TNF will do what? TNF will increase the activation. We are still in intima. Intima is now swelling inward. It would activate T cells. It will activate T cells. T cells in turn will activate macrophages. We have done this like 20,000 times in immunology. Interferon gamma will activate the macrophage, macrophage will activate the T cell. Now the macrophage is active, T cell is active. What will happen? There are going to be growth factors that are going to be released. The growth factors that will be released are very important for the final pathology or shape or maturity of atheroma. This is atheroma development. So what happens is the growth factors, platelet derived growth factor, where did they come from? They came from the damaged, so let me make red colored endothelial cells. So these endothelial cells are releasing platelet derived growth factors. The macrophages are releasing that. Even other cells like the smooth muscle cells are releasing it. Then there are fibroblast growth factors that are being released. Then there are transforming growth factor alpha from macrophages that are being released. In short, the platelets and the other cells present in the site of the atheroma increase the release of growth factors. Now that growth factor increase will cause the smooth muscle cells to start becoming proliferated. Now which smooth muscle cells? There are smooth muscles present in the media. There are smooth muscles present in the media as well, intima as well. And there are smooth muscle cells, their precursors that are running around in the blood too. Three sources: inside the blood, in the intima, in the media. The growth factors specially target the smooth muscles that are present in the lumen and in the intima. However, the media cells are also becoming target of that. Their phenotypes are different. The end result is smooth muscles start proliferating and start migrating from the media to intima. So they'll start coming here, and these smooth muscle would start going up towards the endothelium basement membrane and start lining up under the basement membrane. So this is the formation of a cap now. The smooth muscles are now going to become, they are going to create a cap on top of this. Now as the smooth muscles become active, they release collagen. So there will be lots of collagen as well. They would release peptidoglycans. There will be lots of extracellular matrix developed. So now over here what's happening is, and one more point, please remember, macrophage picks up the LDL, oxidized LDL, through scavenger receptors, not through the normal LDL receptors. Anyways, that's an important point to keep in mind, because the patients who have the deficiency of LDL receptors, they still have the LDL picked up by the macrophage, and that is because of the scavenger receptors. Okay, back here. Now this atheroma has a particular structure. It has a fibrous cap. If we look at the atheroma, normally it looks like this. It has a fibrous cap. That fibrous cap has smooth muscles and collagen as part of it. This is collagen. This is normally stable and strong. This is the maturity of the plaque. The sides, the shoulder of the plaque has active cells. So monocytes are sitting there, T cells are sitting there, macrophages are sitting there on the shoulders, on the side of this thing, and they are still causing more and more activity. So the plaque is actually expanding. Then there is vasculogenesis. So there is new blood vessels, small tiny blood vessels forming. Why? There is tumor growth factor alpha. Tumor growth factor alpha causes angiogenesis. So there is going to be increased blood vessels forming. What is happening underneath? What is happening down here in the media? Look, what do we got here? We had foam cells. These are macrophages that had LDLs in them. Some of them are going to merge and make big blobs of foam, but some of them are going to die. And when they are going to die, what is going to come out of them? Cholesterol crystals, digested cholesterol. So cholesterol crystals come out and they are present here. Now, what else? When the cells do die, what do we get? We get necrosis, we get debris over there, we get junk over there. So that debris is present in the center of this atheroma, somewhere over here. And that debris would invite what? Calcium. So calcium can be coming over as well, and part of the center of the atheroma may be calcified. There might be calcification here. So that is the atheroma that has developed in a vessel wall. Now, if we leave this atheroma like this, with collagen in it, peptidoglycans in it, the cells in it, it's fine, it is stable. Some lumen narrowing is present. However, the problem is, as I said before, the newcomer cells, inflammatory cell, are going to try to start taking bites out of various things, and they'll make it unstable. When this becomes unstable, what would happen is it can rupture. When it ruptures, there are going to be pieces coming out of it, and those pieces would now, one, create a plaque over there. Fibrinogen would come in, plasminogen activity would start. So there is a plaque formation there. There is a thrombus formation there. There is a possibility of emboli over there. Who did this? What caused it? The new inflammatory process. So please remember, atherosclerosis is not just a static process that happened and the boil formed or pimple formed and stopped. No, it is a continuous process. It's a progressive process. Ultimately, it reaches a point where it can hurt. So now, what are the types of atheromas? There are three types of atheromas depending upon what is their composition. The types of atheromas are, there are 70%-ish atheromas that are fibrous, meaning their top and majority of their extracellular material is fibrous, collagen, fibrin, smooth muscles. About 20% are lipid. That is, there are so many cells that have died and no calcium came in, that this is all just lipid, crystals present. And then about 10% are calcified. Their centers are calcified. That is their breakup in terms of their structure. So this is the atherosclerosis